Hi, everybody. My name is Vonne Jacobs. I am of counsel at the law firm Hall Render. We are a healthcare law firm, one of the largest, if not the largest, healthcare only law firm in the country. Our practice focuses only on healthcare organizations, and so all of our clients are healthcare organizations. And I have been practicing as a healthcare attorney for 22 years now. Oh my God, that hurt. And I primarily focus my practice on transactional and sort of general counsel matters with a regulatory focus. A lot of my clients are actually OBGYNs and women's health companies. So I've been doing a lot of work in the last year around all of these issues and working with a lot of the people like the people we're going to be talking to today. So I'm going to start by introducing them. Dr. Anita Somani, who is an OBGYN and a state representative in the Ohio House, and Dr. Shivkamini Somasundaram. Yes.
That's great.
I was determined to say it right.
Nicely done.
Another OBGYN with OhioHealth Physician Group, having been a resident of Cleveland for a while early in my practice and still watching a lot of the activity in Ohio. I want to thank you both for being here and being with us tonight. And I'm going to go a little bit off script because Jen and Jenny got us started on some of the things I wanted to talk to you both about from the provider perspective, being in the trenches on the delivering care side, making care decisions side, also in the making laws and trying to figure this whole mess out side. So I want to start by asking you both. Nita, we'll start with you and then go to you, Minnie. Tell us a little bit about yourself, your background, and sort of what you're doing in this space right now, how you're sort of maneuvering your way through the drama, keeping yourself focused and not totally screaming down the hall every day, all day, or maybe you are, and tell us if you are.
We are. So I'm going to make you feel a little bit better about practicing law for 22 years. I've actually been practicing medicine for 31 years now and have seen sort of, as everyone else has mentioned, the chipping away of reproductive rights started in Ohio back in 2011, 2012. When I was doing my residency, the Catholic hospitals here in Columbus were partnering with Planned Parenthood for reproductive care. So it was a very different environment in the 90s versus what happened starting in 2011, 2012. So again, just like a lot of the other red states, we started with chipping away of reproductive rights, but then compound that with defunding Planned Parenthood a few years ago with Trump being in office. And, of course, Ohio jumped on that and increasing, and I think someone else mentioned this, increasing spending to these pregnancy crisis centers, where now in our budget, currently they're getting like up to $7 million in funding, which takes away from the funding that traditionally went to either the National Qualified Health Centers or to Planned Parenthood. And what that's done and what is really distressing about this is when you talk about people that are, promoting the fact that they're pro-life, what they've actually done is increased maternal and infant mortality rates in our state and in all red states. If you look at the data, the Commonwealth Fund showed like a 62% increase in maternal mortality rates in states that restricted abortion. So what you're doing by restricting abortion, by restricting access to care, is unfortunately creating a unintended consequence whereby people can't access reproductive care. They can't access preventative care like pap smears and mammograms. The half of our counties don't have prenatal maternity care available. A lot of the rural hospitals have shut down their OB units because of the cost and the liability. So we're seeing a really, really, really effectively, essentially shutting down of care. And this happened in Idaho. Idaho has no maternity hospitals left. I mean, it doesn't mean that there's no women living in that state of reproductive age. Yeah. It just means they're having to travel. And when you talk about, why do we have such crazy, high rates of maternal mortality when we are a developed country, you can look at things like access to care. You could, having to travel, not only that, but racism, whether it's you're American Indian or African American or person of color, you're treated differently, or you don't trust the providers, so it affects your ability to access care. Other things that kind of lead to that, it's not just poverty, because we see higher maternal mortality and infant mortality in women of higher socioeconomic class too, that are women of minority. So it's that chronic stress that we talk about, the stress that leads to diseases, just the stress of racism or the stress of inequity, those things. So there is a lot to fix. And that is the struggle that I have at the State House. I know from years of Roe v. Wade, and the fact that even Ruth Bader Ginsburg said, it needs to be codified in the law. We can't just have it as a constitutional amendment. So one of the things that I'm working on is, if it won't go anywhere, but at least, because we have a supermajority here in Ohio, but to have legislation at the State House that protects abortion rights. I think that's really critical. Another piece of legislation that I'm working on is trying to change who gets TANF dollars, so that all of those TANF dollars go to clinics that will provide care, not just counseling about keep your baby and here's a bag of diapers, because that's essentially what happens.
They only need the one, right? It's fine.
Yes. Yeah. And I think we all know, because of Title X, that really when you can space your children, when you can plan your pregnancies, when you can complete your education, it leads to better outcomes for society as a whole, but for women in particular. So I do think that we need to get back to recognizing that abortion, reproductive care, all of these things are not political. They truly are about taking care of people.
Yeah.
And, I keep telling people we are pro-life. If you support abortion and reproductive rights, you're truly pro-life, because that's how we're going to bring down maternal and infant mortality rates. That's how we're going to support women when they are planning their families.
No, I think a lot of people forget that for a lot of women, their OBGYN is their primary care provider. That is where they get most of their health care. So when you're talking about not being able to access care, when you're talking about making it an environment where doctors are now afraid to practice and they don't know what to do, so they quit or they leave, and now women don't have access. Like Idaho, like you described, we were already in a desert situation in a lot of counties before Dobbs, before this conversation. Minnie, I don't know if you're seeing this in your everyday practice, but I know I've heard a lot of my clients who are clinicians in the women's health space talking about, we can't even get residents to think about entering this specialty right now. They are afraid of what it means for them to become OB.
We've seen medical students who travel through the hospital who are selecting not to go to certain states, especially because of the restrictiveness of the abortion issue. We're also seeing that there's a fellowship that's around family planning specifically. So there are residents who are electing to go into fellowship, a one-year fellowship, in order to learn techniques, because they realize, the ones that are dedicated to, they realize how important it is within the construct of women's health to be able to access that. One of the things that I'm seeing a lot with patient care right now is I have more and more young women who want to get their tubes tied, who want to proceed with a hysterectomy. So all of this is actually having the opposite effect in the younger generation who are of childbearing age, where they feel cornered into the idea that like pregnancy is going to saddle them down with a life they don't necessarily want. So they're willing to take extreme measures in order to avoid that, since something simple like a termination is no longer easily accessible. And so both Anita and I've seen, like, we are seeing more and more patients at younger and younger ages saying, I don't want children. I want some permanent treatment so that I don't have the scare or the risk of becoming pregnant without my choosing to be pregnant. Mm-hmm. And so it's actually overwhelming. Like, that is one thing. Statistically, we don't have studies yet to show that, but I think all of us as OBGYNs are encountering that anxiety that young women have about not being able to control things. One of the things that we also are encountering in Ohio is a lot of the legislation in Ohio. There was a 6-week ban that then had an injunction that stopped it. Anita could probably talk a little bit more about that. But there is so much chaos around what you can and cannot do. physicians are struggling with counseling their patients.
Mhm.
Like, I had a couple recently who had a large fibroid tumor in the midst of a pregnancy, and they were considering stopping the pregnancy if the fibroid could not be addressed. And there was so much confusion about, do we have to send them to another state? There are abortion clinics still in Ohio that are doing second trimester terminations. And that is part of what I think providers are dealing with, is this chaos that we're living in where we don't know exactly how to advise our patients. We used to be able to say, I may not provide terminations, but I know where you can get it. Here's a list of people. This is what it entails. You need an ultrasound. There's a 24-hour waiting period, and then you can get your treatment. And it's one of those things that providers are worried about going to jail. We had several department meetings at our hospital that reviewed the policy with a hospital attorney there. I'm part of the system EMR, one of the physician subject matter experts that help with the EMR structure. And we were having a whole EMR build in order to cover legally when we offer termination to patients who are doing so because of the mother's life. And one of the things that's extremely problematic in the context of medicine, we try to treat people before they get too sick. Versus in law, they're like, you can only save the mom if her life is in danger. There are hours that we may encounter a patient where they're getting sicker and sicker, and technically she may not die if we intervene at that moment. And so that is excruciating for a doctor, right? Like, one of the examples is if a woman breaks her water where the baby is very pre-viable, like 16, 17 weeks, we would normally just say proceed with termination, either a second trimester D&E or an induction of labor. Now there's chaos around it. As long as if she doesn't have a fever, and she's
basically
not sick,
she's septic now.
Yes.
That's the lead. That's the lead plaintiff in the Texas case. That was her story.
That's the conversation I'm having to have with a lot of my clients right now, and we are literally on the phone. I am, at least, all day talking. Okay, here's the situation. And I am not a clinician. I did not go to medical school. My mother is sad about that because she wishes I did. But that is not the decision making that I am trained to make. But I am trying to help my clients understand the law does not give me the leeway to tell you, I know it makes sense to you medically, that no, we don't want her to get septic before I can actually treat her. We would prefer to do this way before that becomes a problem, because that's actually a bigger cost, a bigger risk, a bigger problem, all the things we say we don't want in terms of the health of the mother, but we push her to that point. And to your point, Anita, the legislation, if we're supposedly pro-life and pro-health, how does that work?
Is that
I don't know if that's the conversation you're having with your new ballot initiative in Ohio, but I'm wondering if that's where that's going.
I wanted to point one other thing out. There were a group of program directors that did a survey. They did a questionnaire to med students that came out after the match. Essentially, two things happened. One, what Minnie had said, students are choosing not to apply to programs in red states. But the other aspect of it that people aren't thinking about is it's not just OBGYN. There are residents in other programs that are also choosing not to come to these states, because if you think about residency, it coincides with your reproductive years.
Your life, yeah.
And as physicians, they're sort of saying, I don't want to be in a state where I may not have access to care myself as a physician. I don't want to be in a state where I'm going to have to make these tough decisions if I have some sort of, anomaly or some sort of medical condition that leads to, me not being able to terminate. So it's a double whammy when you think about the brain drain that's happening in red states. I mean, I tell this story all the time, but my daughter just finished her OBGYN residency, had offers in Ohio, and went to Portland. She's like, I'm out of here.
Well, I mean, I think that's a real consideration. And I just wonder in the legislature, when we're talking about, are the people who are making these laws actually having, I'm asking this question knowing the answer, that we are not having the kind of intelligent conversations that need to be had about the real life impact of these rules and these laws that, and the real life impact of not being able to be a healthy, productive person because I either have children I don't want to have, I have to get sicker than I need to get before I can get the care I can get. We don't have the kind of people we need in the community to help me because we've scared them all away, or we don't have the resources because we've drained our bank accounts doing all kinds of other foolishness, and now we don't have the budget.
Yvonne, think about the fact that, and Anita can testify, that there was a state legislator who said that we can re-implant ectopic pregnancies, which is completely not. And so we as physicians are sitting here going, there is a fracture from people who understand medicine, and what most often we struggle when we have to talk to somebody who is in the second trimester who has to stop a pregnancy, or the third trimester who has to stop a pregnancy, right? That is a wanted child often, right?
Yeah.
And so, I mean, it's interesting. I remember Pete Buttigieg talked about this in a town hall meeting. He was like, think about that. Think about when someone says they're doing a third trimester termination, these are people who have gone through the pregnancy thinking things are okay, likely, outfitted their nursery, bought clothes for their baby. They are excited about the birth of this child and are faced with this medical decision now the state is interfering with. It's not a comfortable decision for us to have with patients. It's not a comfortable decision for the patient to go through. And yet now we have interference from the government, from people who say they want small government.
Yeah.
That is the craziest part of this. These are people who are saying, I want small government, but I want it in your uterus.
Yeah,
that's the crazy part.
It's deeply
or
embedded.
They're saying my body, my choice when it came to COVID vaccines. And it's like, wait, you can't, you cannot go on that.
So let's talk a little bit about this ballot initiative that Ohio has got, because you just got a major victory. Like you exceeded the requirement to get it on the ballot. So it's now on there. You got 55 counties instead of the 40 something that were required, right? So clearly there is momentum. The population, the citizens of Ohio clearly are interested in this and want this on the ballot. And it's a ballot initiative for a constitutional amendment. Is that right, Anita?
Yeah. So I can actually, what's interesting, so a couple of other things that came out of the data. We had 710,000 signatures. Out of that, we had 490,000 valid signatures, which is almost 70% valid. But most initiatives like this typically run about a 50% signature for valid signatures. So it was really impressive that we were able to, and like you said, instead of 44 out of 88 counties, we had 55. So there were several rural counties that met the 5% threshold to be counted. What issue one is trying to do and why it actually happened is because the writing was on the wall when you look at other states around us, like Kansas and Michigan, Kentucky, all these other states were starting to either protect Constitution rights that were already there that people were trying to get rid of, or they were adding it to their Constitution. And so in January, this all happened really quickly because there was debate about whether to do this in 23 or 24. And the amendment was written very, very tightly, very cleanly by a couple of constitutional attorneys, by physician input. And so the language is intentionally very simple. It covers 5 things. It not only covers abortion, but it covers the right to refuse an abortion, the right to carry a pregnancy, infertility care. And then it doesn't have a gestational age. It just talks about viability, the point of viability. And again, medicine changes. 30 years ago when I started, 28 weeks was considered viability. And now it's like 22 to 24, 24 to 26, depending on where you are and, what the fetus is like. But there's nothing in there, and this is some of the misinformation to confuse people. There's nothing in there that doesn't include parental rights. You have to have parental consent to treat a minor. So that wasn't specifically put in the language. So the anti-choice people are kind of saying, oh, minors can go get an abortion without your consent. Well, that's not true. Second thing that they're throwing sort of to, stick anything they can to the wall is saying, oh, this means your 15-year-old can go have a sex change. You can't have a constitutional amendment with 2 issues. So there's nothing.
Only the one thing.
It's only the one thing. It protects your reproductive rights and it protects your right to contraception and to like IVF. That part is all in there. And it gives you the option to say no. It's literally saying this decision is between patient and provider, nobody else. And so because that language was so simple and so straightforward, the Secretary of State was forced to accept the ballot language. And then, we started collecting signatures. They got 7,000 signatures when they needed 1,000 to get it, to be able to then collect signatures. And then, of course, as you know, so the problem is that politicians at the State House are out of touch with what Ohio really wants. We're so gerrymandered. It's 32 Democrats, 66 Republicans in the House. And then in the Senate, it's 32 Republicans and 7 Democrats. And the reason is, gerrymandering, they gerrymandered the districts. But Ohio, when you look at our breakdown, it's 54% Democrat and about 46% Democrat and 54% Republican. So the State House doesn't reflect what people believe or seeing. And now they're trying to throw stuff on issue 1, like, oh, they're coming after your guns next. Or, it's just amazing. They have no legitimate arguments. So they're just trying to use they're going to come after your Second Amendment rights. They're going to come after your children,
So it's the scare tactics off. And this is on November's ballot. Is it November's ballot? Okay.
Well, we have a special election on August 8th.
Okay.
That's cost about $15 to $20 million. Already, both sides have spent an enormous amount of money. The Save Our Constitution Vote Yes side was funded by a billionaire from Illinois. And then the Vote No side has also been funded by outside money, but not as much as the other side.
Yeah. So I wanted to make sure I got that out there because I know we got to wrap up soon. So for all of our people in Ohio wanting to support Ohio, there's a ballot initiative we can support. We've already talked about, this is where our power lies. It's using our voices, talking about it, getting out the vote. So if we really care about this issue, we would care about women and women's health. This is how we show up. This is what it looks like. My motto, and Priya knows this, my mantra is I create equity in everything I do and everywhere I go. So if I'm going to live it, this is what it looks like. I'm supporting my providers. I'm figuring out how we can support things like choices and ACLU. We're going to get these ballot initiatives done. We're going to keep fighting this because this is what is going to make sure that people get to live healthy lives. This is not, the scare tactic of we're out here trying to kill babies we all know that's not what this is. This is about helping people actually live healthy lives. And
issue 1 has nothing to do with reproductive rights. So if you are someone who's anti-choice, if you don't want abortion, you still want to be able to have your ability to affect change.
Because you get to choose that under issue 1, right? That's the point, is that you get to make that choice.
Right.
So the way the issue, and Anita can talk about this more, the way the issue works with issue 1 is that they want control of ballot measures coming out of the legislature, which has been severely gerrymandered. And what they want to do is eliminate the potential for the population to put out ballot measures. So that's why you want to say no to issue 1, because it's actually impacting how constitutional amendments are proposed and allowed to be voted on. So they made they initially had this is.
Yeah. No, there's 3 things. You're absolutely right, Minnie. That's one of them. The idea that citizens cannot change the Constitution, but legislators can. The other 2 things they did, which is terrible, is right now you have to have signatures from 44 out of 88 counties. They would require 88 counties in order to.
All 88. Oh, wow.
So
it is.
If you don't get signatures from one county, one small rural county or one county doesn't meet that threshold, then the whole thing is out the window. And then the last thing they did, which is horrible, and which we're seeing right now, there's a marijuana initiative that's short about 700 signatures. It would be on the ballot in November also. But because they have, I think, 1,500 legitimate, I don't remember the numbers exactly, but they're 700 short. And so they have this 10-day cure period where they can go collect more signatures that are valid and then still be able to get it on the ballot in November. Issue 1 gets rid of the cure period. So there's no cure period.
Oh, so you don't do it right the first time. You just get, even if it's a citizen-run initiative, okay.
Well, there would be no citizen-run initiative.
Well, you wouldn't even have that anymore.
Yeah,
okay, so since I know we have to let Priya close, I'm not going to get all fired up. But the point being,
don't get fired up. We need everybody fired up.
Look, there's work like Priya knows, there's a whole string of F-bombs that could come out of this, and I'm going to try to behave myself for her sake, because I love her so. But first of all, thank you both so much for all the work that you're doing, and also for joining us this evening and just letting us know what's going on. I know it's a rough road, but we're with you. We're fighting this fight with you. We're supporting you. And definitely, I will be in touch with both of you, because I need to know more about what's going on in Ohio. And
I appreciate what one of the other speakers said. Don't give up on the red states. There's a lot of people living in these states trying to fight the good fight.
Yeah, we got to figure out ways to support you and make this work.